the governor to put a question on a ballot asking about Medicaid expansion to all voters in the state. That's State Question 802. He has not decided which ballot that's going to be on yet, and has indeed filed his own plan, Governor Stitt's plan, Sooner Care 2.0. So I thought that in the interest of illustrating how policy and politics are related very much here in public health, that we could have a discussion about Medicaid in general, and then a little bit of detail regarding Medicaid expansion in Oklahoma. Also, what we'll be doing in this this session is not having so much only myself speaking to you, but we do want to have a chat, and regarding the chat, we want you to be able to communicate either through the chat box where you can communicate, or by raising your hand there, so that we can actually have live interaction over voice with this this session as well. So let me begin with just a little bit of background. I have a couple of things to share with you to frame the conversation, and then we can get into some question and answers and discussion. Just a reminder about Medicaid. Again, this is a combined federal-state program that covers low-income individuals. This slide just reminds us that Medicaid in general is covering low-income women, pregnant women, children, adults and families with dependent children who are low-income, individuals with disabilities, and the elderly. Right now, we're looking at, throughout the entire United States, about 60 to 70 million people get their health care through Medicaid. Here you see that nationwide, children represent approximately 43% of the beneficiaries, and individuals with disabilities represent about 40% of the beneficiaries. And I think it's worth keeping that in mind with regard to Medicaid. Now, just want to show one more slide about who, and these are from your slides from previous session, but just reminding us again who are the Medicaid individuals. And I just want to get to the chat box on my screen here. Yes, so Valana has here, you know, when we get to discussion, if you want to raise your hand, just type raise hand, that would be good. Okay, so regarding Medicaid beneficiaries, I want to draw your attention to this issue about just find the right slide here. I'm sorry, this one. I want to draw your attention to some points on this slide, which I think are key. And that is, that this percentage of these different groups that have Medicaid coverage. So the non-elderly below 100% of the federal poverty level, half of those in our country, 55%, get their insurance through Medicaid. Non-elderly between 100 and 199% of the federal poverty, 40%. When we look at families, all children, Medicaid covers the health insurance for about 38% of all children in the country. But those below the poverty, it's 76% of those children get their health care through Medicaid coverage. And then when we look at elderly and people with disability, when we look at the non-elderly adults with a disability, 45% of those receive Medicaid that way. And Medicaid covers a lot of the nursing home residents, 62% of all nursing home residents in our country. So I think this is important things to keep in mind here as we look at this. and some important facts. The next thing that I want to turn to then is the situation regarding Oklahoma. And this sheet, which I shared with you, was a nice fact sheet which was developed by the Kaiser Family Foundation in Washington, D.C. As I said, not to be confused with the George Kaiser Family Foundation in Tulsa. This is the Henry Kaiser Family Foundation in Washington, D.C. And they looked at details of Oklahoma's population and what would Medicaid expansion do. In other words, if we were to undertake Medicaid expansion up to 138% of the federal poverty level, here you see that's $17,000 for an individual in 2019. This would enable 178,000 adults to become eligible for coverage and represent about 34% of the entire uninsured non-elderly population in the state. Now, this is interesting that childless adults who are low income have a hard time getting health insurance because they've traditionally been excluded from traditional Medicaid coverage and now would be eligible. Now, the uninsured in Oklahoma who would become eligible if Medicaid expanded, we show here 6 in 10 are in a family with at least one person working. So 35% have no workers. 7 in 10 are adults living below the poverty level, of course, and then 27% of the eligible expansion population would be in the 138%. So just again, to go back in terms of putting that in perspective of income. Here we're looking at 138% of the federal poverty level is $17,000 a year for one adult. That's not a lot of money to live on, although I know some of you may be in that situation in terms of your going to school and your incomes. This is a distribution of the racial ethnicity breakdown for who would be eligible under the expansion, the uninsured that would become eligible under the expansion. And about 4 in 10 are middle-aged. And here's the age distribution, and this becomes relevant to what we're going to talk about next. But the older the people are, the more likely they are to have significant health needs. And pay attention particularly to this 55 to 64 population because it's relevant to the next document. 87,000 would be women, as shown here, nearly half. Where do these individuals live in Oklahoma? This map of the state with this sort of color, what we call a heat map, different colors for the different number of uninsured individuals who would be eligible. And you see that this far northeast section and then this southeast and east section on the Arkansas border are the areas of the state that have the greatest needs or higher numbers. All of these are great needs, but the very high numbers, 6,000 or more individuals in these different counties. Now, there are many studies looking at the impact of providing health insurance to individuals who don't have it. With regard to low-income individuals, most of those are evaluating the impact of Medicaid. Remember, we did discuss a little bit, and I included in your materials the situation in Arkansas, which expanded healthcare insurance through a waiver to use a sort of a private option to Medicaid. So an insurance company providing a plan for people, but at low income. But we know from the research that when we expand Medicaid and give these individuals insurance who previously did not have it, these are the benefits that we see. Greater access to care, decreased cost for uncompensated care, individuals' financial situation gets better, so they have reduced debts, less bankruptcies. That's clearly shown. They do use care because they often have health needs that they are forgoing because they can't pay for it. So when you do provide the Medicaid, you're going to see increased use of health services because these people need the care and they take advantage of it. And of course, there were other details in the article by Professor Summers in your reading list that talked about what the evidence tells us about the provision of health insurance and the issue of mortality, and his studies based on the situation in Massachusetts 5 years after they implemented universal health care in their state. They saw a 3% reduction in age-adjusted mortality, which is quite significant. And the next document will look at projecting what the mortality benefits or impact will be in Oklahoma. Finally, then, how would this be financed in Oklahoma? Again, here for the expansion, again, the federal government will pay 90%. Remember, the ratio of what the federal government pays to what the state pays varies by state in terms of the support of Medicaid, varies by state and is influenced by the state's per capita income, with the federal government taking on a greater share of the cost in those states with lower average incomes. And this is the average share nationally for states, so 68% federal, 32%. But that's for traditional Medicaid, depending on the state's per capita income. Oklahoma's even a little more, up in the 70s, shared by the federal government. But under the Affordable Care Act expansion, the federal government covers 90% for a number of years. In fact, it covers 95% for the initial 5 years and then 90% for another subsequent time. So in 2021 and beyond, for a number of years, several years, the federal government will pay the 90% of the cost of expanding Medicaid in our state. So I wanted to go through those. Maybe we'll stop there and see about any possible questions or discussion points from our students connected on the chat based on what we've discussed so far. So again, please look in your, either communicate in the group chat box or just type raise your hand, and you can then be, Vilana will unmute you so that we can talk about your question, however you prefer. Questions, please. Questions or comments. What do you think about this information? Is this striking to you? How do you feel about these facts? Yeah, very, very good question. How does Oklahoma compare to other states? Well, in the next document, so let me get that other document and show you a little bit about how we might compare with respect to people who could be impacted here. This was the document that looked at Medicaid expansion throughout the country, really with respect to mortality benefits, but it has here at the end a table that projects number of lives lost and saved for different states. But of course, Oklahoma has a high rate of uninsurance right now compared to other states. We're around 14, 15%, and we're in the group of states with high rates of uninsurance. We have higher health needs because our population is less healthy, as you know from the United Health Foundation rankings. We haven't, we don't rank well in things like cardiovascular disease and cancer and diabetes and so on. That's why paying attention to the age categories of Medicaid expansion is relevant. And that's what our next document is going to do. So we have not the most uninsured people or need. I think Texas has clearly the most uninsured individuals, but we have a high rate of uninsurance who are needing this. Good question, Chris. Actually, right now, it is not a requirement that physicians accept Medicaid. Some have debated whether that should be made a requirement. In fact, Medicaid does reimburse usually less than private insurance. And in some of the alternative plans that were put forward, there is a suggestion, again, with the current administration, reducing the provider payments even more. But I think this is an issue in areas. I think that there is a desire to work on this policy issue. And in fact, if a health system like, for example, OU Medicine sees a certain number, above a certain number of Medicaid patients, they then receive some added payment, not the old program of disproportionate share, but they do get some added payment. So if it's a system like us at OU Medical Center in Oklahoma City has a very large number of Medicaid patients, there is some supplemental payment to the system to deal with that issue. But in general, of course, it is less than private insurance. And you raise a great point too for policymakers, because there is concern about systems who may not want to take on Medicaid. I can tell you that the rural hospitals in Oklahoma want this expansion, of course, because they will get a lot of patients who now are coming to their system who have the ability to pay to either their clinics or to the hospital. But you do raise a good point about making sure that there's equity in who takes on these patients. And I think the way the current system is they've tried to incentivize people to accept Medicaid, rather than pass a law which says you must take them on, which I think could be challenged constitutionally. If you look at doctors as private businesses, there may be an argument that the government can't force them to provide the care. So the way they're trying to get at that is by a positive incentive. If you take a certain high proportion of Medicaid, then you'll get added payment. That's a very good question, though. Other questions? In the next segment of documents, you'll see a little bit how Oklahoma might compare to the other states in terms of the potential impact on lives saved. But are there other questions on the fact sheet that we've shown? Okay, so I think it is also important. I think the one thing is to remember how many people with disability are covered, or children are covered by Medicaid. I think that's a very crucial element to this. So I want to share this document again here. Go to sharing again. And this was a study done across the nation to look at the evidence that Medicaid expansion would actually result in any lives saved. And I'll come to your question in a moment, Corbin. You have to be resident in your state you get Medicaid from the state that you are resident in, and that's the eligibility issue. So that's a good question. This study was undertaken nationally to understand what the impact is of Medicaid expansion, or what the impact was of not expanding. We have posted this up in Canvas. This was there earlier as part of the readings. But it basically, there were 14 states that still have not expanded Medicaid, and the rest of the states, through various mechanisms, have expanded Medicaid to different degrees. Here, the study focused, this is why I said pay attention to the ages. Here, the study focused on individuals aged 55 to 64 during the study, mainly because it wanted to look at mortality, and that age group is, of course, not eligible for Medicare. They become eligible for Medicare at 65, but they are older adults who have the impact of long-standing health problems and/or chronic conditions such as hypertension, heart disease, diabetes, for example, or who could benefit from early cancer screening such as mammography or colonoscopy. And it concluded nationwide that in the states that expanded Medicaid over the 2014 to 2017 period, because that was chosen, that's when the Affordable Care Act's actions became fully operational in 2014, and Medicaid expansion was realized through to the end of 2017, before the Trump administration took over in 2018, and then began passing executive orders and changes to these things. They wanted to look at the 3-year window. The states that expanded Medicaid, it was estimated nationally, there were 19,200 lives saved. This comes heavily from the work of Dr. Summers, who showed that the provision of insurance does provide a benefit in survival, because people can get access to treatments for things like blood pressure, cholesterol, diabetes, heart disease, prevention of heart disease, screening, early detection of cancers that can be cured, mammography, most notable, colonoscopy, most notable. And these actions, giving people the ability to pay for those healthcare services, can save their life, and does save life. And I think I've told the class of my own experience with my wife, who in 2014 had a abnormal mammogram, just went in for her routine mammogram. And no symptoms, no pain, no lump, no anything, just, regular scheduled routine. The mammogram was abnormal, and the biopsy confirmed a breast cancer. And she went through a partial surgery and then some chemotherapy and radiation. And now we are, this September, again, now coming on 6 years later, with no evidence of cancer recurrence, and doing well. Now, imagine the person who, if she had not received the mammogram, then that cancer would have become evident at a much more advanced and later stage. In her case, it was already involving some lymph nodes in the underarm, what's called the axilla area, which is common for breast cancer. And the next step after that is spread to other organs, and that's when it becomes very, very serious. So it was caught just in time, and I'm sure that there would be a high likelihood that she would not be with us today had she not been able to get that mammogram. So breast cancer is very common. 1 in 9 women in the United States get breast cancer. And it doesn't, pick and choose across different socioeconomic groups. And so poor people who are not able to get a mammogram are left with the consequences of finding out about their cancer when it's at a much more advanced stage and more likely to be not curable. And then you see the non-expansion states, then there were 15,600 lives. They use the term here, lost. I like to use a different terminology. It's that these deaths were premature. Obviously, people are going to die at a certain time according to their life expectancy. But what we're trying to do is prevent, we're trying to prevent premature deaths with this effort. That's what the point of screening and other preventive strategies are, to prevent premature death, which Oklahoma ranks very high in. So you can read more about this in this article, but I wanted to go to just a benchmarking. This is estimated to be the same impact as using seatbelts. But Medicaid expansion then leads to these increased regular checkups, early stage cancer diagnosis, which I just went through with you, prescriptions filled. Many poor, low-income people often have to make decisions month to month about whether they can afford their medication or not, or they don't have enough money to afford their rent and other things. And then surgical care consistent with guidelines, because you need a way to pay for that. And then was a decrease in the 1-year mortality among individuals with end-stage renal disease. That's most likely because they can get dialysis. If you have end-stage renal disease and it continues to progress and you can't get dialysis, then the ultimate effect is an early death. It led to a decrease in the number of people without a usual source of care, either a primary physician or a clinic. And what that means is it leads to decreased use of, potentially inappropriate use of high cost places for receiving care, such as the emergency department. Interestingly, the data is a little mixed on Medicaid expansion and whether you see more emergency department use. In fact, in the short term, you see a little bit more use because people can now go to the emergency department for things that are emergencies, whereas the inability to pay for poor individuals, low-income individuals, is a barrier to people, even when they have things that should be seen in the emergency room, like chest pain, for example. And I hear many stories from my emergency department and cardiology colleagues of people who delay visiting because they're worried about the cost, and that is bad for them. Everything we know about heart disease and stroke and so on is the sooner you get to healthcare, the better your outcome is going to be. Here we have decrease in people skipping the medication due to cost, and less people being testing positive on screening for depression. Their mental health and their sense of security and other things is improved by having a way to pay their healthcare expenses, and more of their disposable income then can go for their living expenses, such as food and housing and other things. And so here, to Corbin's point about the comparison of the states, this was taking the available data from the research on how many lives, how much of a mortality reduction you would get from Medicaid expansion, and applying that to the different populations of these different states. And you have the blue color states are when lives were, or premature deaths were prevented. I think that's a more accurate term. premature deaths prevented rather than just lives saved, or premature deaths which occurred are in the brown color. And you can see here, these are quite substantive for some of these states, okay, based on population. California is over 4,400 premature deaths prevented. So, of course, the comparisons are influenced by population, but if you go down to Oklahoma, it's estimated that there were 476 premature deaths in the state over this 3-year time that could have been prevented among ages 55 to 64, that could have been prevented had we expanded Medicaid. And so this shows you different comparisons. And there are some states on here that, of course, have poor health like Oklahoma. So, for example, we go to Louisiana. Louisiana's, if you look up in the United Health Foundation rankings, Louisiana is very close with Oklahoma on all of the various markers: cardiovascular death, diabetes, hypertension, cancer, other things. And there they saw 764 premature deaths prevented compared to Oklahoma's 476 lost due to the potential impact of Medicaid expansion. Okay, so those were just some things, food for thought for people to think about. And I then now just wanted to come back to our conversation, our discussion. So there's a comment here from Callie. Why are these preventive screenings so inaccessible to a large amount of people when the providers would benefit if these diagnoses were caught earlier? They're inaccessible because people are uninsured and don't have a way to pay for it. That's number one. I think it might be debatable as whether the providers would benefit or not, because physician groups and hospitals, for example, make quite a lot of money off cancer chemotherapy. So in fact, one could argue, if we're catching, your point is a good one, in that they may be able to they'll be giving treatment earlier in the course of disease for these cancer screenings. They may not be giving the same amount of extensive treatment. In other words, there may be less surgeries. The earlier you detect breast cancer, you may just be able to have a lumpectomy and not have to go on. If the lymph nodes aren't involved, you don't have to go on to chemo and even maybe radiation, or most would get surgery and radiation, but you may not need chemo. So in some models or instances, the providers might actually make less money if we caught some of these things earlier, but they would be treating and curing more people, I think, which is important. But the main reason why the screenings are not accessible is, again, has been just people do not have a way to pay for it. Blakely has a good question. Do we think the state that these numbers will help them reevaluate how they're handling expansion? I would hope so. But of course, this is very tied up in politics. I think, a lot of this information is public. Let's take the case of Oklahoma. It wasn't our legislators who changed their mind and said, let's go forward with Medicaid expansion. It was the general public who, after, in the case of 2018, after 8 years after the Affordable Care Act, with the legislature not expanding and not providing an alternative plan. That's the key thing too. I remember in March of 2010 when the Affordable Care Act was passed and a number of legislators came out and said, we're not going to do that. We're going to develop an Oklahoma plan. Well, no plan ever emerged that was viable or feasible or even had any kind of detail to it. So I don't think these things influenced some of these states because they are fixated on the politics and the political ideology and opposing the Affordable Care Act at all means. And they vowed to do that. They campaigned on that, for example, and so they don't want to change their mind. And it was really an effort of the people, right, to organize, to get enough signatures. You have to get over 300,000 signatures on those initiative petitions. Some of you may have signed those petitions. I had various people were on the Norman campus when I was walking between buildings or classes asking, for my signature. It was the people who organized and are forcing the state question because the elected politicians were not acting. That's the case of Oklahoma. That's the case for some of these others. Some other states ultimately did this. In fact, Blakely, I think one of the things that in some ways influenced some legislators more, and it's sad we have to say this, was not necessarily the numbers about lives and about deaths prevented, but about large amounts of federal dollars that were being left in Washington on the table and not brought back to the state. In the early days of the Affordable Care Act, that's what prompted a number of the Republican governors to take that on. One of the most notable, I think, who did the right thing was Governor Kasich of Ohio, a Republican who said, well, he feels that Medicaid expansion was required because of his belief in helping others in line with his Catholic faith. And so I remember he was highly criticized by many members of his party who were going to oppose the Affordable Care Act. Michigan, for example, looked at it and said, there's so much money coming from the federal government, we just cannot leave that money in Washington. These are taxes that are already paid, by the way. It's not a new thing. These taxes are paid, and then the state either decides to get that money or not. But in Oklahoma, this was such a highly polarizing issue. And I remember discussing it with one of the state legislators, a really excellent person, a Republican state legislator from Grove, Oklahoma, by the name of Dr. Doug Cox. And he said at one of our grand round discussions about this was so highly polarized that even if we had a bill called Tornado Aid for Oklahoma, if it was in any way associated with the Affordable Care Act, the legislators would be against it, many of them. So my point of all that is there are more and more examples to go on, but policy is always intertwined with politics. And although the Affordable Care Act has been the most sweeping health policy revision in our country in many years, it's still highly controversial and highly partisan amongst elected officials and amongst voters. So I think this is important. But we hope that in everything I do, I try to get people to focus on the health benefits, and then the economic benefits are sort of a twofer or icing on the cake. Now, Sarah, the governor, does oppose State Question 802, and what he's done is he's had the Secretary of Health and team working with him file for a waiver to CMS to implement a Medicaid expansion under his own plan called Sooner Care 2.0. Sooner Care was the name given to Medicaid in Oklahoma, and he's filed a plan called Sooner Care 2.0, which he announced he was doing under, in my last lecture, the last slide had the details of the Trump administration affordability opportunity program that they announced in January, where our governor wants to expand under a block grant and to have two other notable differences. That he wants work requirements for these individuals to be eligible, which has been tried in some other states, and there's literature on whether that's useful or not. And he wants to also charge them a premium, a small premium maybe, or a premium, but he has filed that plan with CMS and under the president's program. Remember the big debate again about block grants versus entitlement. The Medicaid expansion we went through under State Question 802 would function as an entitlement. It's an expansion of Medicaid. And so whatever the rules for expansion were that Oklahoma implemented, anyone who met that eligibility would be eligible for that benefit. And that, to some, that keeps it a little open-ended financially to the state. And that's what some people are fiscally worried about, the long-term obligation of paying for this. But the governor wants to do it under a block grant and have work requirements and premiums. And those three things are very, very different to what the State Question 802 is doing. Do we think he will shift his stance? No, I think it's highly unlikely he will do that. I think because he campaigned against Medicaid expansion. So he was in a bit of a bind because he campaigned against Medicaid expansion. When the State Question 802 got enough signatures to put it on the ballot, he had to do something. So he wants to expand, but he wants to do it in the way I've outlined, which are the key distinctions between Sooner Care 2.0 and Medicaid expansion. Well, I think, let's see what others think about that before I answer. Let me turn it back to you, Sarah. What do you think, those things? Should we have work requirements for people, given the data I showed you? Should we have work requirements for people who have low income and need Medicaid? Anybody who wants to answer? And should we have premiums for those individuals? Look at the incomes. $17,000 in 2019. Can those individuals afford to pay monthly premiums? And what about the evidence that says, when you have premiums or those type of things? I think there's also some other cost sharing piece, but when you have premiums, those added costs at that level of income can be a barrier to either signing up for it or utilizing it. But what do others think about this? Remember, this goes again to the tension about entitlement programs versus block grants, and it goes to the tension of what is the role of government, and it ties right into, is healthcare a right or not? Yeah, Valana raises a good question. What do our people on the call know about, from our prior discussions, what proportion of the uninsured are not working? Anybody? So prior classes and data, we showed you that among the uninsured across the country, about 75% of those people have one or more family members who are working. And Sarah just brought in the other very important point that many may not be working because of disability. So I think the governor's plan would allow for an exemption from that if you're disabled, according to the the Trump administration, this thing applied to able bodies. So if you are disabled, you would be able to get Medicaid, providing you've been certified as disabled and not able to work. And that's not necessarily an easy process. People have to go through that. In which case, for the reasons pointed out there, the work requirement thing is more of optics than of actual or sort of ideological thinking by people who view this almost like a welfare program. And that's been a historic challenge. How do you view Medicaid? Do you view healthcare for low-income individuals like welfare? Anyone want to answer that? I think that goes to the question of whether we believe healthcare and access to healthcare should be a right that all Americans have, or whether you believe it is not. That is an important philosophical or cultural issue that we have to address. But I want to hear from you other thoughts. What do others think about this? Let's see. Krista, it's not off topic. It's very much on the topic. Again, the connection between politics and policy. So polling that I saw a little bit back suggested that it is likely to pass. And I think that's part of what had motivated the governor to speed up and bring his plan in, because he views this as a commitment to an expense that Oklahoma can't make. Now, I think under his plan, you can look this up, but I might be wrong. I think he was committing something like $150 to $200 million from the state towards his Sooner Care 2.0. But that's it. That would be capped because that's a block grant. Whereas if we commit the same amount, as a state to begin, then we get them, either way, we'll get the 90% support from the federal government. But under an entitlement program, if those number of people grow, and there may not be a more important time because of COVID-19, because of the low price of oil, Oklahoma is likely going to have quite severe economic impact. The country is going to have recession, but we may have even more severe than some other states because of the double whammy. And the oil price is in many ways unrelated to COVID, but exacerbated by it. We will have revenue challenges going forward. So I think people are concerned about cost. And those, on one hand, say that we can't afford this. What do others think about that? So I think, polls, Krista said that there was a pretty good majority of people favoring this, but that was months back. What happens once a lot of the ads, typically what will happen is once the date for the ballot is announced, and now the governor either has to put that really now he could put that on, really the only option I think is going to be the November election. There was the options that he could have put that on the primary or other, or a runoff election. But I think those have all passed now, or coming close to passing, or past the deadline for him to do it. So it's likely this will be on our November ballot. So I think that's interesting. Okay, Valana, thank you. Good, good added information. So that is a pretty solid support. How long ago was that? Do you know? That poll? Of course, at the end of last year. And of course, Valana knows this from her long time in the health department. Those numbers, are maybe a starting point, but once the ballot date is finalized, then you'll have people on both sides running a lot of advertising and advocacy to try and change people's minds. So we see this with tobacco taxes, for example, where most Oklahomans support that, but then when the big tobacco starts running their ads on it, they can move those polls fairly significantly. So, but these numbers are very encouraging at the end of last year. One other point is, from this slide that I showed you, if we go back, Medicaid eligibility, let me just share that one again. Here, you see that children are a big chunk of the beneficiaries, and individuals with disabilities, and not necessarily people in the 55 to 64 range. So, is there a way you think Oklahoma should prioritize who we cover? Should we push more of the Medicaid expansion resources to women with children, low-income women with children, and covering them? Or should we put more of those resources to the childless adults, but who might be in the age of 55 to 64, who have many healthcare needs that they're not getting taken care of, and who are the group that are very likely to have an impact on their survival and preventing premature death? How do we prioritize that decision if we can? Anyone want to comment? It's a very tough choice. I think it illustrates the challenges we face in health policy when we have finite resources, right? And we have two very worthy groups. I certainly wouldn't want any child in Oklahoma to go without health care, and I wouldn't want a mother to be facing the terrible situation of wondering whether she can take her child to the doctor or not, and maybe have a child suffer consequences because of that. At the same time, I also, think about people who are in that 55 to 64 age group, where something like being able to get a screening for breast cancer, like my wife did, or a colonoscopy, or getting their blood pressure treated and preventing a stroke, for example, or something like that. I think those are important needs as well. And so these are really challenging policy issues. Let's ask our group who would like to weigh in on your thoughts. Do you think, how will we handle this? What do you say to the argument about, the state can't afford to do Medicaid expansion in the traditional way, that there could be too much obligation once the federal government's sharing of 90%, expires? What do you say to that? So if it costs the state 200 or 300 or 400 or 500 million dollars, what do you say? Do you know some other numbers? Just, to know we're looking at a state budget is in the range of almost 8 billion. I think it was close last time. Don't quote me on that, but you can easily Google that and see. So it's in the several billions. What do you say to the argument about that we just can't afford to do that? Anybody in the chat or raise your hand? I would like you to be more vocal on this. Okay, Samaya, thank you for weighing in on this. Yeah, so that's one approach, right? To reprioritize our funding. Defense, of course, is always the one that is talked about when we're debating domestic spending versus, the defense budget versus discretionary domestic spending. And the United States spends more on defense than the next several countries combined. I don't know at the latest data whether that's 6, 8, or 10 countries combined, but it's a lot. We spend a lot more on that. But that whole area employs a lot of people and so on. But yes, we could. So Samaya says we could reprioritize our funding. In the state, there are things that could be looked at. The legislature already did that, like last week, or I think it was last week, right? Because they looked at the tax revenues coming in for this fiscal year, which ends in June 30th, and they saw that they are down fairly significantly. So they're going to have to bring money from what we call the rainy day fund, and we're going to, and they decided they wanted to take money from one of the governor's projects, the digital optimization fund. He had a program that he wanted to upgrade digitization of the state agencies and so on. And they said, well, we have a more urgent need for that. This has created a bit of tension between the governor and the Speaker of the House, for example, and some others. Callie says we should see how this could work in Oklahoma as it has for other states. And we can't just negate the fact that this has been very helpful in many other states when we rank so poorly in our health and have these serious health needs. So I think that's a good point. Others, what do others think? So one strategy to these policy questions is reprioritizing. Yes, Blakely, let's unmute you. I can do it. Okay, Valana unmuted you. Go ahead.
Adding on to like the last point about reprioritizing funds and stuff, I worked in DC last summer, and we actually had a project where we had to take the national budget and like rearrange it to like make people happy with like the money and stuff. And I think like trying to rearrange to like get things what we think are priorities versus like what other people think are priorities can be like difficult. But I think what Callie said, like, we're not going to know if it works in Oklahoma if we don't try it at least. And so like maybe trying some type of form, like maybe starting off small and then, okay, if the small works, then working it up and making it bigger until we finally can figure out something that works like for our state directly, because it's not going to work the same in every state and stuff.
Right.
Like people in Oklahoma might think that like certain money needs to be spent more on something else in healthcare, or like different topics of like what money should be spent where and stuff depending on the state. And so I think we just have to like start small and then work up into a bigger, like
Okay.
work up to the bigger solution.
Right. And so remember, the rule is that the allowance of expansion is up to 138% of federal poverty, and the numbers we showed you were if we did all such people. So your point is good. The state could decide to set just a little bit lower cap, for example, up to 125% of federal poverty or something like that, or maybe cover fewer but proceed. Um, um, that's a good point. Let me turn it back to either you, Blakely, or anyone else. Another way to talk about this, and Blakely, you're going through that exercise of the real tough choices of reallocating those funds and different interests and different people's priorities. That's really, really helpful, because that's what actually happens. But let me ask you the question another way. In Oklahoma, what's more important for our people, for us to spend on, than taking care of their health care for those who don't have it? Anyone want to try to think about prioritizing those things? I think these are hard choices, but I think what you're seeing from the polls, Valana quoted, is that people are starting to think about this, and people who that's the other interesting thing. The other interesting thing on this issue is that once people receive the healthcare or some of these benefits, they might look differently at this, right? So in the last lecture I posted, last two, I highlighted the two plans that were put forward by the Republican Congress immediately after President Trump's election as alternatives to the Affordable Care Act. But remember, neither of those plans got rid of the the pre-existing condition, that they wouldn't allow companies to deny based on pre-existing condition, and the ability of parents to keep their children on the plan up until age 26. Those two provisions were so popular. Once people had experienced those benefits and given to them, it was very difficult to take that away. So maybe to Callie's point, if we try something, and to Blakely's also, we try something, as more and more people experience the impact it has on their life, it may begin to change the thinking. Okay. I hope that that Oklahoma will really think about this very carefully, and that people will think about the impact this has on quality of life and on life expectancy for people who are not so fortunate and who are working at the low end of income and not able to get health insurance on their own or through their employer. And I think that it's something that I think is going to be discussed. And I think right now, and certainly I think there'll be potentially more people in need right now in the short term with the COVID-19. A number of employers, even though they've been furloughing or laying off people, people are always eligible for what's called COBRA benefits, but that's expensive. So some people may lose their health insurance as a result of this economic downturn. And it becomes important to have this safety net capability. But it may also challenge the state's budget very significantly over the next few years. So these are all important policy steps that we have to think about as we go forward with this. But I hope that this has given you a little more background. I wanted you to have some more background and discussion about this, because I think once we get a little bit further on in COVID, hopefully we've bent the curve and we'll be able to conclude the shelter at home and other things and start a transition back to a more normal situation. Then this will begin to get media attention and discussion as we come up to the election or the date when this is on the ballot, whenever that's going to be. Are there any final comments or questions that people would like to ask? Okay, well, thank you. I hope the discussion has been helpful to just highlight a few of the different issues. These are always very complicated. And that's what makes policy interesting and fun. And if you have an interest in the politics and connecting policy and politics, that's always there. It's almost hard to separate many aspects of public health policy from the actual politics, because you have to get it implemented. So I wanted to give you a little flavor of that on an issue which is very important to Oklahoma, and which we hope we will decide this fall, assuming the election all goes ahead as planned. And I don't think yet the COVID is going to influence that, but we never know what happens. So we hope the governor will assign a time for this to be on the ballot. He will continue to move forward with their request to do it differently through CMS. Those will be, I'm sure that there'll be discussions with him and with the other proponents of the State Question 802 as we move forward to a final vote on the question. Samaya asks, yes, it's okay, because everybody's asking, and thank you. Right now, we're hopeful that we can, so I think COVID will affect, so I assume, Samaya, you're meaning the fall semester. Summer has already been determined to be online instruction. Fall semester for OU, I'm optimistic, I hope, and we'll continue to work that we may be able to begin transitioning back, but I think there will be, it will affect it in some ways, because maybe, our class, for example, the health policy class is quite a lot with more than 80 students. I'm working with the Norman provost to look at ways that we could still have some classes, but reduce the size by having more sections or by having hybrid. I think it's very likely that you'll see some combination of online and or whether online instruction, whether it's asynchronous, the type of recorded lectures that I've been doing, or synchronous, this kind of live discussions and format. I think it's very likely you'll see some combination of that with possibly in-person classes if the data show us that the shelter in place and social distancing has brought the pandemic under control in our population, and that we can keep a low, steady number of cases that can be controlled by testing and containment of the infected individuals. So on that point, what we've had to do in the US is we've basically had to put the whole country, over 300 million people, at home for a while, shelter in place. The president didn't do a national order, but all states, with possible exception of one or two, really did that to varying extents, but most did to quite a significant extent ultimately. Well, we've had to put the whole country that way. It's estimated that for every COVID case, there is probably 8 to 9 other people with the virus who are asymptomatic. So if you take the total number of cases in the US, which is between what now, almost 600,000 or something like that, and you multiply that by 10, you have about, best guess, we have 6 million people in the country who've maybe had the virus, exposure to them. Yet we're putting over 300 million people at home to control that. I hope that gives you a flavor for that. That's because we didn't have the ability to test as much as we needed to at the beginning and really investigate the cases very aggressively and isolate and contain them and all their contacts, both symptomatic and asymptomatic, so that the virus was able to multiply and spread within our population according to its R0 value. Remember, the R0 is the average number of people that will be infected by one individual. And for COVID, it's about 3 plus or minus. And the fact that people are very infectious in the first 4 days and almost pass it on to someone else in 4 days, whereas they may not, more than half won't show symptoms until 5 days or later. So for all those reasons, we have to bring it under control with the shelter in home social distancing. If we get it down to a very low level, we can begin to be transitioning back to some in-person activities, but not in very large groups. So I think some combination of in-person classes plus online instruction, both synchronous and asynchronous, is likely what you'll see for the fall semester. But that could change depending on what we see in progress with it for the next little while. That reminds me then to say, as we close, Valana will post, if she hasn't already, I want to do 2 more of these live sessions with the class on the last part of our course, chapter 14, where we're going to talk about a policy analysis paper, right? And you have to, and then the take-home exam will be some assignment of a policy analysis. So I want to have not only some pre-recorded things for you on that chapter 14, but I want to have a couple of these discussions going through that together, so you have the opportunity to ask questions and interact, because I think that I like to hear your voices and talk with you too. Yes, Valana is posted. April 27 and April 29th will be live sessions like this talk during our regular class time, where we'll really delve into that policy analysis as preparation for you to do your take-home final exams. And then just clarifying again, I think we did post the message, but we are complying with the Norman policy that the student gets the choice to have their grade as a letter grade or as a pass-fail grade, depending on your wishes. And that happens at the end after you see those things. So those are a few things, but I'll look forward to being back with you to talk about the policy analysis. You have the quiz coming up, and the details are posted about what will be covered on the next quiz. Those lectures and chapters focus on the slides and the lecture, and you'll be fine for that. Any final questions? Okay, well, I thank you all, and I want to wish you have a good day. And yeah, thank you, Corbin. Appreciate it. Thank you all. Really appreciate it. I'm enjoying being able to interact with you more too. And earlier on, after spring break, the only reason I didn't as much was I was pulled in so many directions helping with the various response to COVID. But we'll look forward to more engagement this way going forward. So thank you, and have a good day, and good luck for the quiz. Thank you all.